Okay, good afternoon. I think we're ready to begin again. Thank you everybody for coming back. My name is Nina Fakaris. I'm the president-elect of the National Association of School Nurses. I practice in Oregon. So from Aaron's slide, I'm one of those West Coast nurses that work in the schools out there. So I currently serve 4 buildings. I have about 5,000 students on my caseload. So that's kind of some of the differences between West Coast and East Coast. My job this afternoon is to talk about professional preparation requirements. So really, what does it take to be a school nurse? So when we think of what a nurse is, oftentimes we think, you know, a nurse is there to help the doctor. Right? That's the old image of what nursing is. So when we think now about what a school nurse does, oftentimes we think a school nurse, well, yeah, they do Band-Aids and hand out medication. So what I'd like to do this afternoon for just a few minutes is to clarify our image and what it really does take to be a school nurse. And I'd like to start by talking about the definition of school nursing, and this is the National Association's definition of school nursing. So school nurses are a specialized practice of nursing. Our foundation is public health. We provide primary, secondary, and tertiary health care in the school setting. We do protect and promote student health. We facilitate normal development and advance academic success. So we do help with Band-Aids and we do give medications, but when we're doing a Band-Aid, we're also teaching that child about infection control and wound care management. And when we're giving medication, we're teaching that child about medication compliance and how medications work in the body and what they're for and what they're not for. We also work with staff so that staff understand the appropriate needs of students with chronic and acute healthcare conditions within their classrooms and how to manage those. Continuing our definition, school nurses, we are grounded in ethical and evidence-based practice, and we really do bridge education and healthcare. We are often the only healthcare provider in the school setting. Now, granted, the school setting, they're all about education. They're not about health care. So oftentimes, one of the most difficult things for new school nurses to understand is education language and how do we translate what we do and know in nursing into education speak. So we are that bridge. We provide care coordination, working with families, healthcare providers. We help identify community resources and community partners. We do advocate for quality student-centered care. So we understand that each child is unique and that each child has individual needs that school nurses must ensure are met if they're going to be successful academically. We collaborate to design systems that allow individual and communities to develop their full potentials. So we do work with individual students and families. We also work with staff. Ideally, we'll work with administrators and school district staff, school boards, to look at appropriate health policies. We work in the community to ensure that resources are there for our population based on our population need. So we do a little bit more than just sit around and help the doctor. But so from my presentation, what are the professional preparation requirements to be a school nurse? Well, first, you have to be a registered nurse, and those are licensed by their state board of nursing. Second, the National Association believes that a school nurse should have a minimum of a baccalaureate of science degree in nursing. Baccalaureate education develops competencies in leadership, critical thinking, quality improvement, and systems theories. It cultivates the ability to translate research into evidence-based nursing practice and gives us a foundation of current and emerging healthcare issues, including healthcare reform and funding. We also believe that many school nurses are required to have state school nurse certification. I know in Oregon, to be called a school nurse, you have to be certified through our Teachers Practice Standards Commission, which requires about 40 hours of continuing education. Right now, it's a little odd because the only place you can take that class is in Washington State, so I haven't quite figured that out, but we are required to be TSPC certified. I know New Jersey also requires state certification, and I think Alex is going to get into that a little bit in her presentation. We also recommend and highly recommend and encourage national certification. There is a national certification board for school nurses, and that is supported through our NASN efforts. So really, what does it take to be a school nurse? Well, really, a school nurse is a specialized, independent healthcare practitioner who often is the first healthcare provider children see. We are always the first healthcare provider children see independently of their parents, the times they come alone into the health room. And it is our job to make sure that their healthcare needs are met so that they can be in the classroom learning. So I think now we'll move on to our next presenter. Alex is going to go into more details about the law, and we will take questions after our panel is done. Thank you.
Hi everyone, I'm Alex. As Carrie said earlier, I will be graduating very soon with my JD and MPH. And I'm here to tell you guys what the laws actually say with requirements for school nurses and what they can and can't do.
I can't hear you back here.
Oh, you can't hear me?
Much better.
Much better? Okay, so I just need to... So I'm here to talk about what the laws say. School nurses play a vital role in promoting student health, but the states differ dramatically in what they require of school nurses. So I'm going to present the results of a 50-state survey, including DC as well, that kind of talks about what the laws require for staffing and training of school nurses, as well as what they permit. This policy scan was aimed at looking at what the laws and regulations for each state specifically require, not the practice of nursing generally. So I won't be really, there's no interpretation of the Nurse Practice Acts in this, but more those explicit provisions that say school nurse in them, or school nursing services. And throughout the presentation, I'll be discussing primarily what most states require and permit, but also highlight kind of unconventional statutes and regulation provisions. Great. So with regards to requiring school nurses, so only 22 states mandate the provision of school nurses within schools and school districts. However, 5 states require schools to provide health services or nursing services for students, but don't require school nurses. And additionally, 5 states have permissive languages encouraging or allowing school districts to hire school nurses. And then with regards to staffing ratios, so 5 states encourage staffing ratios but don't mandate it. 16 states actually mandate it. And 3 states make their staffing ratios contingent on funding. So more specifically, 15 states require certain staffing ratios, as I just said. Most require school districts to hire at least 1 school nurse. However, there are some more interesting provisions and provisions that span kind of the gamut of staffing ratios. So Vermont requires 1 school nurse per 500 students, and every school must have a school nurse. DC requires 1 registered nurse per school for a minimum of 20 hours a week. Georgia is the optimal level that has been discussed by NASN as well, of 1 school nurse to 750 students for elementary school, and then increases it to 1 to 1,500 for middle and high schools. West Virginia requires 1 to 1,500, but only through 7th grade, so no requirements for high schools. And And then Tennessee is 1 to 3,000, but you must have at least a school nurse for each school system. Louisiana has this weird maximum staffing provision, which could be interpreted as limiting school districts' abilities to hire school nurses, which is you must hire a school nurse for each city or parish school system, but the State Board of Elementary and Secondary Education shall not exceed a statewide average of 1 school nurse to 1,500 students. And then Oregon only requires school nurses for students with disabilities, so a ratio of 1 to 225 for medically complex students, 1 to 125 for medically fragile students, and 1 to 1 for nursing dependent students. But they encourage a staffing ratio of 1 to 750 students for students without disabilities. Now, that brings me to, the permissive staffing ratio requirements. So, Indiana and Iowa and Oregon encourage school districts to hire school nurses at a 1 to 750 ratio. Virginia, it's 1 to 1,000. And Utah, it's 1 to 5,000. And then some states make staffing ratios contingent on funding. So Alabama requires 1 school nurse for each local school system, and additional school nurses distributed to schools based on average daily membership. But the funding provisions don't take effect for school nurses until a ratio of 1 to 500 exists statewide. So this helps, schools are encouraged to hire school nurses, as opposed to in Arkansas, ratios are effective upon the availability of state funds. So all school districts should have 1 to 750, and then based on a higher concentration as determined by the Department of Education of students with disabling conditions, but these are only effective upon the availability of state funds. In Delaware, you must have 1 school nurse per reorganized school district, or you risk losing funding. So we also looked at the minimum level of training required for school nurses. So 26 states require a registered nurse to be a school nurse, but they also require you to have a permit or an endorsement or a certification or a credential from either the Department of Health or the Department of Education or some other department. And some examples include, so Idaho requires you to have a pupil personnel services certificate and a school nurse endorsement from the Department of Education, which requires an RN and certain education and experience. And Maine, you must be an RN, but you have to have a certification for school nursing from the Department of Education. And Illinois requires a school nurse to hold a professional educator's license, but school districts may employ non-certificated, I can't say that word, non-certificated registered nurses for the provision of nursing services. 2 states require other training or experience to be a school nurse, in addition to being a registered nurse. And when I say other training, Connecticut requires an additional 1 year of full-time experience working as a registered nurse, but you don't have to have a credential or anything else. And Indiana has an additional clinical practice requirement. 11 states only require a school nurse to be a licensed registered nurse, and 3 states allow school nurses to be a registered nurse or a licensed practical nurse, which I know is kind of contrary to what your delegation authority within your Nurse Practice Acts. And then 8 states allow LPNs to supplement, or school health aides to supplement staffing provisions or staffing ratios. And 2 states, Alabama and Georgia, set out a staffing ratio of 1 registered nurse to 5 LPNs. And then another thing we looked at during the survey is what the laws say, and in their explicit delegation of authority school nurses' authority to delegate certain tasks to unlicensed personnel. So many schools use volunteers to assist the school nurse in providing health services, often in the absence of a full-time school nurse. And we found that 28 states explicitly allow a school nurse to delegate medication administration. Now, there are a variety of different statutes and provisions within that, whether it be prescription medication or over-the-counter medication, but generally 28 states allow some form of delegation. 47 states allow people to delegate to allow school nurses to delegate epinephrine administration. And the network also has additional resources on their websites regarding stockpiling and non-specific epinephrine kept in schools. And then 26 states allow school nurses to delegate insulin or glucagon or have some sort of diabetes care assistant. And 5 states allow for the delegation of naloxone or an opioid antagonist in schools, but West Virginia actually explicitly prohibits this in their statute. And 6 states allow for respiratory distress medication to be delegated to an unlicensed assistant. Oregon allows you to delegate the administration of adrenal insufficiency medication, really specific provisions, and Texas allows for the delegation of anti-seizure medication. And for the most part, all of these delegations are to trained, unlicensed school personnel. 2 states, Kentucky and Louisiana, give a general grant of authority to delegate, presumably within the confines of their Nurse Practice Act, and Nevada defers to the State Board of Nursing on this. So the State Board of Nursing publishes a document that states what school nurses can delegate. We also looked at the explicit authorization of screening and testing for school nurses and what states can do, what services they can provide. And so 10 states allow school nurses to do hearing assessments. 15 states allow for vision assessments. 9 states allow for posture or scoliosis assessments. And 5 states allow for BMI assessments. 3 states, I know we talked about this a lot, but only 3 states allow for head lice, for school nurses to check for head lice. So, and we're talking explicit delegation. 2 states allow for physical exams, 2 states allow for blood pressure, and 1 state, New Jersey, allows for drug testing. 5 states allow for immunizations to be given by school nurses, and Louisiana allows for school nurses to screen for communicative disorders, and Mississippi allows for school nurses to screen for developmental disorders. Interestingly, other states require similar exams to be performed, but do not explicitly authorize the school nurse to perform them. And some states require school nurses' assistance in these exams and screenings and testings, but don't allow them to perform them. And for instance, Delaware does not authorize a school nurse to provide any screenings, but requires them to record the results in the students' records. Anyways, and as I think I discussed at our lunch, school nursing doesn't end in the classroom or at schools. Sometimes they go on field trips, and you may be violating the laws of another state. So we looked at nurse licensure compact states and found that 27 states are members of the compact, allowing nurses to practice both in their home state and other states. I know. Yep, so in conclusion, you can see all the states are kind of across the board as to what they require for state nursing services, and there's no uniform legislation statewide. So the results of this survey will be on the network's website. These slides will be included in that for more information. And then if the laws and regulations are changing in your state, we'd like to keep it updated. So we'd love to hear from you guys and let us know what's going on. Great, thank you.
Oh. And then where do I find mine?
It should be on the desktop, so we'll click out.
Where?
Click the X.
This?
No,
No,
the one
this.
right over. Yeah. And then, do you see name of yours by any chance?
I'm not seeing it unless it's this one. Oh, no, Medicaid. Here it is. Okay.
That one.
Yeah. Okay, slideshow. Oh, boy. I got through the, there we go. Okay, hi, I'm Denise Chrysler. And I originally came here thinking I would talk about certain things, mainly FERPA. And then I listened all morning to all these comments about data, and then I got all energized at lunchtime, and I'm like, can I have 2 hours now to redo my PowerPoint? So, you know what? I'm going to talk about what I feel is most relevant right now, and I'll get through whatever PowerPoint I can, and if you want to get me on the phone, I'll talk your ear off about FERPA, and I have so much detail in this PowerPoint, you're like, I didn't even need to hear her speak. So, I want you to know 3 things about me. First, I am an attorney for the Network for Public Health Law, and one of my specialty areas involves the legal issues around the collection, the sharing, the use, and the protection of data. And as we hear here, data is foundational. It's foundational to public health. It's foundational to achievement at school. It's foundational to the health of individuals and the health of the broader communities. It's certainly foundational as part of that to health equity. So the next thing I want to tell you is I spent many years as the privacy officer for my state health department. And it's probably because it started in 2003, the year that the HIPAA privacy rule became effective. I think I became the privacy officer because I was the only one willing to read the law. And that is a real prerequisite. But because you all may need to work with attorneys and people who specialize in privacy, we have a bias. It is sometimes we just, so we see things as if in doubt, if things make us feel uneasy because they require professional judgment, say you can't do it. And it's really short-sighted that way. I mean, that's how attorneys work. You ask an attorney a question, you know this. You ask an attorney a question, what is their answer to you? It depends or no, either one, depending on what mood they're in that day. But you usually want to ask, you want to say to the attorney, this is what I want to achieve, help me get there. But attorneys are very risk averse, and so are privacy officers. And they just think of the trouble you can get in and there are big fines out there, don't let me minimize that, but the trouble you can get in if you share something and things go south. They forget the trouble you can prevent if you are willing to share data in a responsible manner. It's sort of like having your light under a bushel, your lantern under a bushel basket. I think that's the saying. How can you advocate if you don't have data? That you don't use your data, you don't share your data? How can you educate the public? And how can you really use that data so it's useful if you're so afraid to use it, to share it, to work with others, to solve problems. Which brings me to the third hat I've worn in my career. I spent 6 years as a school board member. And it was an urban school board, and I want to let you know, when I left, I was so discouraged. I just said, I hope, and people heard me yak at my table, I hope that the new school board members are more skilled than I was in solutions to improve student performance and improve the lives of our students. The reason I was discouraged, this is hopefully will help you. I was discouraged because all we did was pour over results, scores for our schools. We would look at them with regard to, maybe poverty. I think we had like educational level of mother as a factor, but we did look at different factors. But when I left, I realized that my community held the schools responsible for for how those students did and how they succeeded in life, when instead of, in other words, you needed to solve the issues of poverty, of transportation, of hunger, of lack of housing, violence, and access to health care, and the list goes on and on and on. And my solution was always, we kept losing our best students because they'd look at our test scores or, blah, blah, blah. And we had schools of choice where for no cost you could go to a really, wealthier school district, 20 miles away. And my attitude was always, let's do a swap here. Let's have all the high-performing staff come into our schools, and then our students go, or our staff go there, and then let's look at the test scores. But this is why data sharing is so important, is you're not only responsible for the education of your students and their success, their attendance, their participation, but heavens, you're responsible for the entire community. And that's the next point. So school boards. I never once had anybody talk to me as a school board member about what school nurses are, what they do, how many we have, what our law requires. I never had anybody bring data to me that told me what are the health issues that our students face and what do our schools need so they have students who are capable of attending school, of participating in sports, of playing, of concentrating, blah, blah, blah. Never did anybody as a school board member do that. And one thing school boards do for public schools, school boards set your policy. They hire a superintendent, they fire a superintendent, and the superintendent and staff implement that policy. And somebody asked me, well, what about policies related to health issues, access to health, to nursing services? And for us, I know we use the National Association of School Boards templates for policies whenever we updated policies. So instead of like school board by school board, it would be good to have templates that really reflected today's demographics and today's challenges in schools. So I would really urge you to not let your school board be as ignorant as I've been, but to really understand who has the power. They run for election. They're usually a little sensitive to being responsive for that reason. But that's something that I wished I had done. Next, my title page. What's in a title page? Well, the title page is FERPA, its impact on data sharing by schools. My title isn't data sharing. How can organizations and communities share data so we are all able to succeed as a community? And something people talked about here as we just started is the importance of relationships, the importance of partnerships. Data should be all about reciprocity, not the public health department saying, oh, schools, we'd like you to share data with us, and here, Denise will tell us, Denise will help us with FERPA, so we can explain to you why you can share this data with us and all the steps you need to do to go through that. So just as a indication, since I wanted to save so much data. This is the kind of data that health departments have. Everything from lead screening, newborn screening, on and on. Medicaid, because a lot of, at least at the state level, will implement the Medicaid program or state children's health plan, county health plans, so they have a lot of data about diagnoses and outcomes, regulatory data, including issues about asbestos, lead abatement, et cetera. WIC has lots of information. In order to qualify WIC, you have to have a whole battery of tests that reveal certain deficiencies in order to get supplemental food. And then it goes on, vital records, all sorts of registries. Cancer registries, almost all of this data is identifiable by name, is available for linkage if you can get through the legal quagmire. Disease surveillance data, clinical service data, especially local health departments provide clinical services, and emergency preparedness data. In looking at reciprocity and data sharing, just briefly, this is how I approach it. People come to me and say, oh, we want to share data, blah, 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 and on and on and on. And let's just assume the case definitions all match and you can even line up the data. Then let's just assume things are interoperable. And often I find you don't even get to the lawyers because you can't work out those issues first. But let's say you get to the lawyers. The first thing I say to you, let's map it. Let's map and let's see, you know, I'm hoping you know what data you want because I need to know where the data is coming from, because each of those organizations are subject to various laws and they all may be different. Schools have FERPA, and then they have, you know, I assume IDEA has its own confidentiality provisions, Medicaid does, I know, and on and on and on. So we need to know who's sharing what data, what kind of data elements, because we need to look at, is that data identifiable? And what is the definition of identifiable? Each different law has its own definition. This stuff just requires somebody who is willing to take the time to systematically go through every single applicable law and look at what it allows. You know, does it require consent? Can we develop a consent that covers, you know, that covers HIPAA, that covers FERPA, that covers all these various laws, so one consent will do ya. So we go through that, and then we let's see, I need to know from whom to whom, but I need to know what that data was collected for. What was the purpose? Because if it's going to go for a different purpose, it's called a secondary use of data, and I might have to look at the significance there. So I will go on and on and on and ask you 1,000 questions and to map out all the issues. Then I go through and find all the laws, and then I systematically work through them. And sometimes I can find a solution, sometimes I can't. I think, let me just go, so many laws, so many laws, so many laws. And okay, general rule, can't share data unless you have consent or meets an exception. There's lots of exceptions I can tell you about. FERPA, if FERPA applies, HIPAA doesn't apply. Please go through my PowerPoint when it's online. But the de-identified information, how you de-identify information under FERPA, and then directory information, school personnel are allowed to go in to, say, an immunization information system and update addresses. That's not considered confidential information. It's permitted to be done unless the parent says no. Of course, here's the consent. Other school officials sharing data or information among yourselves. There has to be a legitimate reason to have that information for an educational purpose. If you don't, you know, if there's nothing you can do with the data for a purpose of education, then you don't need the data. So this is the one I want to mention in closing. Public health agencies and other agencies can help you with your mission. Now, it's a lot harder for you to help them with their mission because FERPA is one of the more restrictive of the privacy laws. But public health can come in and help you with your mission to educate students, to ensure they're not absent, to, you know, ensure they can participate, to develop an comprehensive asthma plan, on and on and on. The key is Public health is helping you with your mission. They're really your agent, your consultant. And then the law does allow data sharing to the extent necessary for public health to help you. And so there are mechanisms. You just, somebody talked about how you needed to translate nursing jargon into education jargon. Well, the same thing. How do you take public health and data related to public health and relationships and frame it in assist you with your mission as a school district language. And if you are able to do that, often we can find a way for you to be able to accomplish that purpose. So when public health is knocking at your door for identifiable information, talk about how you could have a partnership so that public health helps you with your mission, not you help public health with their mission, even though the missions are one and the same. With that, I have a whole bunch more slides. I hope you'll look at them. Thank you.
All right, everybody. Well, I'm messing around with this. I am Sarah Summers from the Network for Public Health Law Southeastern Region in beautiful Chapel Hill, North Carolina. I'm also part of an organization called the National Health Law Program. And that is, we have an office in Chapel Hill, obviously, and then also an office in Washington, D.C., and then in Los Angeles as well. So I'm going to take 30 of the precious seconds of the time and ask people, who in the room is not from Maryland? Okay, so we got a fair amount of Marylanders. How many of you are with a state government? How about with the federal government? No, I'm just kidding. One lone federal government guy. And other than Carrie, Denise, almost Alex, and me, are there other lawyers in the room? Guiltily admitting it in the back row. So, the last time I was in a room like this, I was sitting where you're sitting, and it was civil procedure in the deadly part of the afternoon, and I was probably asleep, and I'm ashamed of myself now, because now I know how it feels to be up here at this hour. But I hope I can invigorate you with the good news about Medicaid, combined with the bad news. So, anyway. So full disclosure, in the next 15 minutes, I am going to explain to you some very basic structural legal facts about Medicaid, some general concepts of how Medicaid works across the states, and then the aforementioned, when Beth was talking, recent policy reversal that makes it easier to claim for certain services to be covered by Medicaid. I am not with the Federal Centers for Medicare and Medicaid Services. I am not with the state Medicaid agency. I approach this from the point of view of a beneficiary's advocate. So already I can tell you, if you have intricate questions about medical codes and data sharing and how you can bill in your state, I'm not the person to answer them. And I wouldn't do it either, because that's something that, for very particular information, you should get from your state Medicaid agency and from the federal government. These are just the general concepts to get you started, so that you know where to look and what the generally right answer should be. So with that, let's dive into Medicaid. Okay, you all know this. Medicaid is the publicly funded health insurance program that at last count covered 36 million children on Medicaid and its related cousin, the Children's Health Insurance Program. That is a heck of a lot of children. And where do we find those kids? School. So when you talk about Medicaid's federal legal structure, you have to really differentiate between adult services and services for children. For adults, Medicaid functions like, more like a private insurance program. The federal law sets forth a slate of services that either must be covered or may be covered. They're referred to as mandatory or optional services. Mandatory services for adults are basically your bread and butter medical services as they were conceived of in the 60s. Hospital, nursing home, physician services, the like. clinic services. Then there are optional services, which include a lot of services that are optional only in the legal sense. There are crucial services like dental services. Prescription drugs are optional services, although all states cover them because it would be ridiculous not to. Different kinds of services that are aimed at people with disabilities. Rehabilitative services, personal care services, and the like are optional. However, as you know perfectly well, these are crucial services, not just for people with disabilities and chronic conditions, but for everybody. For children, forget all that. Throw that out the window. There is a big blanket concept for children known as the Early Periodic Screening, Diagnostic, and Treatment Benefit, EPSDT. A super sexy and memorable acronym that has not helped anyone to understand exactly what the program is. Periodically, there need to be naming contests for how to have a fun-sounding name like CHIP or something like that. But EPSDT is what we have. EPSDT is better conceived of as sort of a package, of services. It consists of I keep thinking I got this. Okay. It consists of screening services, as the name would indicate. And these include medical services, including developmental and mental health, vision, hearing, and dental services. These are prescribed by the federal statute. And within the very broad parameters, the state Medicaid agency sets the frequency of these screens and the content of the screens based on guidance from the American Academy of Pediatrics in particular, but also other child health experts, American Academy of Pediatric Dentistry, et cetera. You will have in your state Medicaid procedures somewhere in a manual or in a regulation or some other place, what they call a periodicity schedule. That means at certain intervals, children must get in there being the doctor's office or the clinic or wherever, get medical screenings, get vision screenings, get hearing screenings. In addition, there are what they're called, again, just a super helpful lawyer way to refer to it, interperiodic screenings, which just means when you need it. It's something that a teacher, a parent, someone else who comes into contact with the child can say, I think I see a need for a screen, and that can be covered by Medicaid. The idea is you get them in at preset intervals to detect conditions before they get worse, and also enable coverage of services when you suspect that something is going wrong. The teacher thinks, as our wonderful keynote speaker said earlier, something's up. This kid, I don't think this kid can see. So you can get them in to have a vision screening, and along with that comes coverage for glasses. Along with dental screening comes coverage for treatment of tooth decay, fillings, the like. Hearing can include, hearing aids and other assistive technology to enable hearing. So that's the S part. And I will say, most states have it down pretty well, the early, the periodic, and the screening part. That is used to diagnose a condition, and then what comes next is coverage for treatment. This is the part that's more challenging and sometimes doesn't actually happen in the execution. And here's the statutory language that I include here because it's important to understand the true scope of it. It's all Medicaid-covered services, meaning services that can be covered under Medicaid, if it's in that optional and mandatory list, necessary to, quote, correct or ameliorate a physical or mental illness or condition. So what that means is that in the statute, there's a whole long list of categories of services that can be covered. Your state Medicaid agency can say, we're covering A through L for adults, but not any others. Can't do that for kids. If the screening reveals a need for the treatment services and it can fit within a Medicaid category, it needs to be covered. Okay? So that's much broader, much less like private insurance than adult Medicaid. And so I'm giving these here as examples of the kind of particular services that can be covered. Medicaid statute doesn't say you must cover appendectomies, you must cover tonsillectomies. It says you must cover physician services, nurse midwife services, in and outpatient hospital services, clinic services, medical and remedial care. Within those things come eyeglasses, hearing aids, dental sealants can be covered, nursing services, behavioral health services, case management, transportation, okay? And the scope of that is prescribed by federal law. Like, for example, nursing services that can be covered, they're defined broadly in the Medicaid Act in a variety of ways. It can be part of a hospital service, it can be part of a clinic service, it can be nurse practitioner services, private duty nursing services, which is in-home, beyond the scope of visiting nursing, usually for people with severe disabilities. And then beyond that, it's circumscribed by your state licensure and practice acts. So very broad. Everybody, if you read one thing, if you remember one thing from this talk, go find this wonderful guide. It's something that was prepared by the last administration's CMS, Centers for Medicare and Medicaid Services. My colleague at NHELP and I worked on this guide, and it's intended to be a collection of all of the sub-regulatory guidance, all the letters from CMS, all the emails and stuff that they wrote to states explaining further the scope of the EPSDT requirement. It has a treasure trove of wonderfully helpful information, including a nice general section about coverage of services in schools. CMS, under the previous administration, was really into school-based health centers promoting the coverage of services in schools. We'll see what the new administration has to say about that once they get beyond sort of the flurry of whatever they're up to right now. Anyway, but this guide is very helpful and really gives some wonderful general guidance about how to deal with EPSDT. Okay, so here's the civil procedure after lunch stuff that could make you fall asleep, but it's about money, if that makes it any more exciting. Medicaid is based on a concept of federal matching. The federal financial participation is the federal share of Medicaid expenditures. There's a lot of details under this, but generally for dollars spent by the state on Medicaid services, they're matched by federal dollars. At least 1-to-1, if not at a higher rate, depending on the poverty level of the state and other factors. So in order to get FFP, the magic words, it needs to be a covered service, it needs to fit into one of the service categories, and you need to have a Medicaid participating provider. Another important Medicaid concept that impacts schools is that Medicaid is the payer of last resort. If there's private insurance, if there's other sources of insurance, those need to pay first, and Medicaid comes in last. And then Medicaid also rests on the concept of legally responsible third parties. Medicaid, with regard to adults, they'll pay after a third party payer ponies up the money. With children, in a lot of cases, especially for screening, they'll do what's called pay and chase. They'll pay for it and they'll go after the third party to get it. So these concepts, the federal financial participation, that is what enables you to get the federal money, the payer of last resort, and legally liable third parties, led to a concept known counterintuitively as the free care policy. The free care rule or free care policy held for over about a decade. It was an interpretation by the federal government that said you can't have any federal financial participation for services that are free to the community at large and therefore free to Medicaid beneficiaries. What this meant was if there was a service provided in school that everybody could get and was free, Medicaid wasn't going to pay for the Medicaid eligible kids. This was a problem, obviously, because that meant that the finite resources of state dollars or county dollars or district dollars are being depleted, and without possibility of a match. In 2014, CMS said, we're not doing this anymore. There'd been a lot of work behind the scenes, including some of the organizations and people in this room, to say this doesn't make any sense. Finally, there was an interpretation by an administrative court within HHS that said this is not correct. So CMS said, we want to get more quality health care. We want to improve health of communities. We want the public agencies and the like carrying out these responsibilities to have better leeway in ensuring that health care is provided. And so now we're going to have another source of FFP. So everybody celebrate. Now, the reality is there's a lot of barriers, there's a lot of barriers between implementing this, as all of you are nodding ruefully, because there's a lot of different things that need to be dealt with. Does your state Medicaid plan allow for this to happen? Your state is, Maryland certainly, and a lot of other states are largely dominated by managed care. What are the managed care plans doing? What are they obligated to do under their contracts? Do they know what to do? And then, heaven forbid, we talk about the interoperability of systems and collection of information. These are the things that people are grappling with. The Healthy Schools campaign and National Association of School Nurses and others are involved in this learning collaborative called Healthy Schools, Healthy Futures. And they have had a couple of meetings sponsored by the Department of Education and with participation from CMS, where they're working with groups of state stakeholders at the state agency level, Medicaid, education, et cetera, to try to work through blast through some of these problems. And CMS, has pledged to be, in the previous administration, had pledged to be helpful to really explain how you don't get burned. All the states are sitting in there like, okay, we remember the 90s. We remember what happened when we got slammed for billing for free care, for not properly separating Medicaid coverable services from administrative stuff, and big fines from the state. And that is a horrible blow to your state Medicaid program. We've always known that special education, not always, but for decades, it's been clear that services, IDEA services, that are also Medicaid coverable services can be covered, by Medicaid if you jump through all the proper hoops. Fits into a Medicaid coverage box. Provider is a Medicaid provider, and you're compliant with whatever your state licensing requirements are with regard to the scope of the service. So services like personal care services or one-on-one nursing was easier to cover. There are more tricky coverage questions with regard to things like ABA therapy for children on the autism spectrum. I could bore you, like Denise said, I could bore you for hours on that. I mean, we could have a whole symposium on a day of this, of Medicaid reimbursement, but I'm just trying to give you these basics. Beyond special education services, though, is the new frontier that they're trying to work out. So the broad generalizations here are, Medicaid can reimburse for school nursing services if someone in the chain is registered as a provider. The district, the school-based health centers, say a community group that employs school nurses. The children have to be Medicaid eligible, right? You're going to have to be able to separate amongst the kids who are Medicaid eligible and who aren't. The service is coverable under Medicaid. It fits within a Medicaid box. And this can include IDEA services. But that's been established for a while. So I think I made it in time, right? Email me. Call me. I'm happy to talk about this. We have a lot written about this, and I refer you enthusiastically to the Healthy Schools Campaign website, where they have a lot of interesting information about this.
You have tons of time left. We all read so much.
We get an A.
A for being on time.
Does anyone have a question? Don't be intimidated by this. I'm not going to make you sing. Any questions? Yeah.
Keep passing.
If Marilyn Comar states that school health services need to be delivered by the health department and the Board of Ed, how does that help or enhance with the Medicaid? Because could we do things under the umbrella of the health department if you have that MOU? Does that make sense, what I'm asking?
Yeah, let me sort of back up on that one. The reference to COMAR, for those of you who don't know, is the Code of Maryland Administrative Regulations. And so I understand you to be saying that it requires that all school services be delivered. What was the phrasing again?
Through the health, by the health department and the Board of Ed, but it looks different in each county.
Right.
Specify.
Right. By the health department and Board of Ed. So assuming that the regulations weren't changed, which they could be, the Medicaid agency could change them, but if they kept it the same, the health departments presumably are licensed as Medicaid providers, and then as you said, the parameters of their relationship with the school district is governed by some kind of memorandum of understanding. So if I recall correctly, Well, and let me just say this, to put in a shameless plug for something that we did with the Healthy Schools campaign. We had a survey of state Medicaid plans and any references they had to not just the free care exclusion, but also anything about school-based services, and that's available on my website, on NHELP's website. And also, we surveyed managed care contracts to see what, if anything, they said about it. The thing about it is that the managed care contracts are pretty ephemeral. They're amended each year. At one point, there was an issue with Maryland's state Medicaid plan, which is the blueprint, where they had recited the free care exclusion. But I believe, like I said, I'm not sure. I think they asked for them to take that out once they didn't have to anymore. So I think that the kind of regulation you're talking about is probably a vestige of getting, of being concerned of not running afoul of this type of restriction. So it's something that may be being revisited, as we speak, and should be revisited. But even within that, I think it's negotiable for sure, as long as the particulars of the relationship between the Board of Education and the Health Department are there. Of course, you're suffering from the same thing that North Carolina suffers from, and a lot of states do, that don't have a state public health department that that oversees everything, or not, that has more power over the locals. Everything looks different. We have 100 school districts. We have 50 health departments, and so everything looks different. It makes it hard to give people good instructions about how to deal. But this is something, that's something that it's doable. I see a question.
Thank you all. I really appreciated the state-specific in particular, so I'm wondering if we can do maybe just a brief look back. Are there patterns in states that you have seen recently from a legal landscape that folks are taking on from a sort of progressive, we really like what they're doing, or a more conservative perspective, we're not sure that that's going to be great? And looking forward, in 2017 with a new administration, are there any things on the horizon that you think states will have to respond to from a legal or policy perspective?
As far as trying to implement the reversal of the free care coverage exclusion, there are about a dozen states participating in this learning collaborative. Maryland was one of them. New York, Massachusetts. Let me think. Who else? Colorado. Tennessee, South Carolina, Louisiana. Louisiana has some, this may surprise you, but Louisiana has some very, had some very forward, had gone pretty far along in trying to implement this reversal of policy, and had some good models. They had a previous Medicaid director who was acting as a consultant who, this was sort of his passion project, and he was a doctor as well. And so that they made a lot of progress with that. South Carolina was pushing along early, getting its state plan amended. California, I know that may not surprise people, but California also had some innovative things going on. So in that area, as of 12 months ago, where a lot has changed, but those were some standouts, I thought.
There it is. So sort of tying back to our lunch conversation and Alex's presentation, have there been legal challenges when legislation sort of focusing from the Board of Ed standpoint conflicts with boards of nursing or boards of medicine who sometimes control MP practice in certain states? Like, the laws apparently, or the provisions in various laws don't always coincide with each other. So who wins out in that situation? Have there been any legal challenges to that?
So I'm unaware of any legal challenges to that, but I will say a lot of the Board of Education or the education laws and regulations are, throw in this caveat statement, subject to what the Nurse Practice Act says, for the most part. So that tends to win out most of the time. Otherwise, that's about it.
I know in Oregon, so Alex had our information up, right? So children with disabilities, it's a 1-to-125, 1-to-225, 1-to-1. And our data is clear that school districts are in violation of those ratios, even though it is law. We have yet to be challenged. However, the Department of Ed is pretty nervous about that because they realize all it will take is a parent to challenge the Department of Ed, and then they will have to come in and tell school districts, you have to hire nurses, and we don't care if it means you have to, lay off 10 staff, you have to get nurses to comply with this law. So I know our state is pretty nervous about that. They're trying to figure out ways to increase funding to increase school nurses, so we at least meet those ratios that are required, but we haven't had a legal challenge yet. I know there has been legal challenges over nurse delegation in the schools, and that legal challenge said that no, it is up to the school nurse to determine, not the principal. It was a case a principal said you have to delegate this procedure, and the school nurse did. The person didn't want to be delegated to, and they sued. Unfortunately, the school nurse lost too, but the law did come out to say, no, really delegation is the authority of the school nurse, not the administration. So I know that's been one case that has been challenged.
Any other questions? Oh, right.
So in terms of services, I'm curious about services like care coordination, for which we don't have reimbursement for nurses on the other side of the house in terms of public health or private health care where nurses are doing care coordination, but that's a lot of some of the work that school nurses do as well, is care coordination. Is there reimbursement for that?
Yeah, I mean, this is the kind of thing that got schools into financial trouble when they were activities that weren't considered were considered too administrative. And there is a specific category of services called case management. There's also a category of targeted case management, which has slight variations on it. And so as long as the services that one is providing fit within that general definition, then you should be okay. But it's something that has to be trod carefully from the beginning. We do Freedom of Information Act requests every few years to get everything on EPSDT we can, including typed letters from the early 90s, and there was a lot of back and forth in the late 90s about case management and care coordination and the like. And there is, and so there is you can see the pattern of how it went. States that were worried about this would reach out to CMS. The state Medicaid agency would say, dear, their regions, dear Region 4, we want to do this. Is this legal? And they would basically make sure that what they were talking about. And so we have some letters where states presented specific scenarios, and the feds said yeah or nay. Of course, the meaning of the definition of services can change, the interpretation of the agency can change, but they do provide some good. Sort of general guiding principles. In addition, the strategy guide that I showed you all the picture of, that has some discussion of case management in it as well. Yes?
Yes. Do you know if, similar to how electronic health records, EHR, has been given for physicians and all in hospitals to get some form of reimbursement for getting on board with that, does CMS has something in place for schools? Because the challenge is going to be funding for, doing something to have that billing and reporting.
Yeah, absolutely. I mean, you're absolutely right. That's what's going to happen. There is, in general, there are there are certain incentives for getting on board with electronic health records in general, not just necessarily for doctors' offices. I don't know if they specifically apply to schools. I just don't know the phrasing of that in my mind. But I know that there are various opportunities to get what they call enhanced federal match for the state. I'd be interested to look into that very thing. Nobody is here from Healthy Schools Campaign, are you? Okay, then I will follow up on that with Carrie, and I'll tell her what I find out. I guess I'm the Medicaid consultant, so I should know this, but I don't know that exactly.
That's a great question.
All right.
There's one more.
Oh, there's one more? Okay, we have time for one more. Talk fast.
Have you heard of anyone having success with getting reimbursement for vision and hearing screening that's done in schools?
Yeah. Depends on how they do it. In fact, I think Chapel Hill School District does, and I'm not. And I believe it's because they're able to separate out the medicated, non-Medicaid kids, and they are a Medicaid provider. So, and I'm sitting here trying to rack my brains. We did a whole thing on coverage of vision and hearing screening services in managed care systems, and I'm trying to think if it talked about schools. But Beth is raising her hand.
I was going to say Delaware does that with vision, hearing, and immunization review.
Yeah.
Yes.
All right, everybody. We're going to take a few minutes to get our Skype connection together for the next panel. We have someone joining us from Sacramento. So just be back here ready to roll at 3 o'clock. We'll start promptly at 3. Feel free to use the bathroom, go out in the courtyard, get some sun, get some vitamin D. Thank you to our panel.